Hi, everyone. I'm Hejie Cui. I'm a postdoc scholar from the Center of Biomedical Informatics Research. And I'm here today to talk about our RAISE grant proposal, Cura Bench. So as we are talking about the responsible AI topic today, I want to specifically focus on very important, but currently still far away from the safety deployment perspective, which is the evaluation. So we know that healthcare AI models has shown very promising results in a lot of papers and discussions, but a proper evaluation still remains difficult. And this will stop us from a self-AI deployment in the real clinical settings. So the first challenge is that there's a lot of papers on having the leaderboard for showing different leading LLM models on each of the benchmarks. But this is still far away from the realistic evaluation because basically, how does the model perform on a leaderboard of USME does not necessarily translate to their utilizations in the real world setting. And the second perspective is that manually creating a benchmark, say from scratch, that I want to specifically evaluating a group of people or a group of patients that suits my personal needs, then I need to collect all the samples for this group of people and then have a group of clinicians to help me verify the whole creation of the benchmark and per instance level. And this can cost more than $10,000 per data sets. And this is also time consuming and which stops us to utilize it in the real world setting. And another recognized issue is that the current benchmark schema is mostly static and limited. And here I show an example of analysis of the existing evaluation benchmark in the electronic health record setting, where we find that some existing benchmarks actually has this temporal distribution issues. Most of the benchmark questions are grounded to the most recent visits, where if we want to evaluate, say, a particular patient groups or different race or a different time grounded questions, then it's feel difficult to regenerate the benchmarks and create it from scratch again. And this motivates us to create this proposal about Cura Bench, which is a benchmark data generation system for healthcare AI evaluation. And this is a joint work with Professor Nigam Shah from which is the main PI, and Sami Kuyaju from computer science, and Keith Morse from the pediatric hospital. And so let me show you how does the whole Cura Bench frameworks work. So we first of all, we do the EHR dental sampling. For example, we can take the STAR AllMap data response rate from Stanford Hospital, and then we can basically this contains the longitudinal records that spans years for real patient data sets. And with this as the grounding, we then use a group of prompting methods to create a configurable system that can generate benchmarks or say data sets from the real sightings of the patient records. And here are the few configurable dimensions that we think about are useful for the benchmark creation, where you can specify the clinical specialty values or the demographic statistics, or there are different kinds of clinical tasks. For example, I want specific this clinical decision making for a group of people, or this is for this gender or the other. Also this can specify over different, this is expandable for additional dimensions, including more patient populations or temporal coverage for this configurable dimension. And the next stage is that we pick the representative samples from this generation data sets and put it through a clinician quality controlled process, which we can include a group of people, a group of clinicians to review the generated data sets and make changes through this iterative generation process of the configuration system. And finally, we will get the customized benchmark system that will serve the purpose for the realistic deployment settings. And with this whole generation system, the potential impact is to basically reduce the cost by say more than 90% compared with manually created from scratch. And this will enable the, say, the localized AI model evaluation for the specific settings that will realistically used in practice. And also, the core idea of the system is this configurable scenario for clinical settings or specialty values. And you could also add more dimensions to the system. So basically, begins with config files in the whole computing system, and it will output you a group of question-response pairs that will be used for the evaluation settings. And then you can test on this generated benchmarks and see which models could help more in this specific scenario. And we are also testing a whole bunch of LLMs on a taxonomy like named MedHum. So this is like extensive work from MedHum that will enable more configurable dimensions. And for the first time, you can create a benchmark that has never existed in the world and serve specially for the settings that can benefit real patients. And overall, like this is a whole benchmark creation system that will enable responsible AI deployment and ensure that there's real patients benefits from this evaluation benchmark. And that's it. So I'm happy to take any questions.
Wonderful presentation. What are the efforts to make this available to anyone who wants to implement this in their clinical setting?
Yeah. Yeah, that's a good question. So basically, this whole effort is mostly like an engineering engine behind the scene, where we would provide the whole system from the configuration file to the generated. Basically, the input is a configuration file where the users can change the specification for this configuration file. And the whole pipeline system will serve like behind the scene, and there will be like saved data set and benchmark from the user configurations.
Thank you, Hejie. My name is Jeff Hancock. I'm really excited to share some work with you that is a seed grant from RAISE, which we're really grateful for. It's in collaboration with my co-PI, Lee Sanders, and a team of folks working with us, Angela Lee, Sunny Liu, and Hejie. The basic idea here is that, as Hejie was talking about, if we can build and anticipate trustworthy healthcare systems in the future, we also then need to consider the other side of the trust equation, which is us humans. And so if those systems can become trustworthy, how do we think about people trusting them? This is a really important context. We know that there are a lot of primary healthcare needs that are unmet in the United States, and AI can play a real important role there. However, there are a number of communities that both do not get sufficient primary healthcare support and also have underlying trust issues, especially around technologies like AI, in part because the distribution of AI across the population is uneven. Many communities get very little access to AI. To give you an example of how this problem can be exacerbated, we can think about historically marginalized communities, like communities of color. They have not only low trust right now in AI systems, in part because they're not getting very much access to them, but also historically have low levels of trust in healthcare, in part because of the ways they've been treated by the research communities over the last several decades. So how do we go about trying to create this solution around primary healthcare support in order, to build trust to accomplish that solution? So to do that, we're working with a team of people that know how to partner with communities in order to ask questions to get at what are the barriers to trust. And so we're taking this sort of three-step approach to building trust with AI in the primary healthcare space. The first, let's see here, is to really get a sense from people on how they think about AI, how they're thinking about AI within that context of healthcare. What are the barriers? What are unique to them? Who are trusted messengers? These are the core questions that we actually don't know anything about right now. Once we have that, we can develop measures that are culturally and linguistically sensitive to that community so that we can actually measure the degree of trust that come with different kinds of designs and different ways that they can be, these technological solutions can be implemented inside primary healthcare. Last, once we have those, and again, this is a seed grant, so we're at the very beginning of this, we can inform design guidelines that are unique and customizable to specific communities in order to build the trust so that these systems can be deployed within them. To do that, we're going to rely on some of the expertise that my group has developed over the last several years in building digital strength. These are digital literacy programs that are tailored to certain communities or populations to help them be able to resist things like fraud, scam, misinformation. We just finished one large project with older adults, for example, who have some vulnerabilities. They tend to get targeted with misinformation a lot and fraud a lot online. We were able to scale up some interventions that reached over 10 million older adults during the last election, and we showed that we demonstrably improved the quality of their browsing behavior for several weeks after the intervention. So there are real ways that we can build real improvement here. And we'll also partner with Lee Saunders' group. Part of the groups that he runs is the Health Literacy Solutions Lab that looks at building linguistically appropriate interventions in federally qualified primary healthcare centers. So by combining the expertise of our two groups, one around working with communities that require specific needs in the digital space, with his work doing the same thing but in primary healthcare, we're really confident that we can build ways of understanding the trust gap and then bridging that by building technologies and implementing them inside primary care that addresses them. To give you a sense of what some of these methods are like, we use a wide variety of qualitative and quantitative methods. Here's a qualitative one where we show a participant in one of our studies an example of how AI could be implemented. So they're presented with a scenario and then asked a series of questions, concretely asking them about different kinds of situations. Here you can see an AI solution that's called an LLM, which would be meaningless to most participants in most communities. Is this a positive thing for trust? Is it better to create an anthropomorphized agent? These are all questions that we just don't know yet. So we're really excited. I think there's a massive amount of opportunity here. All the amazing work that's being done to build these AI tools won't work for these communities until we can work on that human side of the trust equation. So thank you for the support, and thank you for your attention. Really appreciate it.
Well, I think I'm building on today we have heard a lot around medical education, preparing the next generation, and I'm not gonna ask the question of whether if you're using Stanford SecureGPT, DAX Copilot, or any other sorts of tool. But have you been using it enough that you start to stop reading every single word and maybe skimming through? Natalia this morning has mentioned about automation bias and the risk that we run into as we use more of these products. The problem here has been the widening gap between how technology is developing at the scale of light and how education systems has been lagging in healthcare for years. And for that, our team has developed Impact, improving medical practice through AI competency training. My name is Alaa Youssef. I'm an AI research scientist as well as a medical education researcher and innovator. Working with an amazing team, we are developing Impact. Impact is an educational intervention. And we were very fortunate to be one of the RAISE Health Grants recipients to really have an educational intervention that addressed this long-standing gap. And the goal here is not to focus on teaching coding or teaching existing knowledge around AI, but it's actually the practical clinical necessary tools that we need in every day for clinical practice. You have seen a lot of these key challenges this morning mentioned, from ethics, whether you tell patients that AI is involved in their care, If you have an AI deployed in your clinical setting and you have a number of alerts, how many are false positive? Do you attend to all of them? If AI is 98% confidence, is it confidence because it's confident or confident and also hallucinating? Maybe another aspect. Is it matching based on a pattern, or do you trust that for rare disease? And if a nurse is questioning, how do I explain to the clinical team the responses I'm seeing? I really don't understand, but I think it's right. And if you have entered the same response to GPT and you try it again, perhaps you're not going to get the same response. So what's the right answer here? All these are challenges clinicians face every day. And to develop that, the problem here is we don't need a content where it's going to be one answer that will be using standardizedly across. We need a new way of thinking in education where we're thinking, how do we resolve uncertainty? How do we have a framework, and how do we approach those questions that will bump up every day in clinical practice? And for that, Impact is going to address this at 3 levels. First level is building fundamentals, where we are building a curated, publicly accessible database for Stanford and beyond, that we hope that this catalog will democratize access to the AI knowledge base so that people around the world, for healthcare professionals, can really access this resource and be able to get onto speed on the clinical necessary questions that they need to think of when AI is in their clinical care. We'll be sharing evidence-based resources, evidence-based literature, as well as resources. And if you're very kind of keen to get started, we are already underway with the first component. And you can see a live document here. You can scan this QR code for a live document of where this curriculum is shaping up. Next, and this is the most important part, medicine, despite a lot of knowledge, medicine is a competency-based profession. That means it's not only important that you know what you do as a knowledge, but what you do with this knowledge is super important. In medicine, we all go through assessments and evaluation, but we don't have any ways of assessment or tools to even understand whether the clinicians who learn with AI are ready to practice with AI or not. And therefore, we'll develop, based on real-world scenarios, competency-based components that allows clinicians, learners to practice. What does it mean to evaluate an AI tool? How to read the AI output? And how to ensure it's embedded in a health system? What are important questions about workflow I need to be asking myself to know it's safe for my patients? Most importantly, most of the addresses to AI education has been a cookie cutter where we're addressing some component. The goal here is not to build a massive scale or add burning kind of like content to be learning about, but the goal is to have a clinical knowledge base that both undergraduate medical education, graduate, and competency-based learners across the medical curriculum and continuum can actually use the same knowledge to communicate around questions related to AI. Think back about the questions around GPT. The problem with GPT is that there's always going to be that 5% where it's going to make an error. The problem here is we need to have a knowledge that allows us to understand what is the boundaries of this technology, when is it safe for me to trust, when it's safe for me to override, and when should I be questioning? It's because we believe that human plus AI will lead to better care still. We believe that it's important to address this educational gap. And so we are fortunate and grateful for the RAISE grant, and we hope you join us if you're interested in medical education. This is the amazing team behind this work.